Dr. Roshmi Gupta, and this is the AIOS Sujata Savitri Rao Award of 2017 in the Orbit and Oculoplastics. She'll be talking on risk factors for orbital implant exposure after Evisceration, a case control study of 93 patients.
6 minutes.
Good morning all. It's my pleasure to present the risk factors for orbital implant exposure after evisceration. This was presented last year. So one of the very distressing things for both patient and surgeon is exposure of an orbital implant after a relatively straightforward procedure like evisceration and implant. So I've had the misfortune to treat a significant number of exposed and extruded implants treated in the last several years. Now, my worries were, these were other surgeons' patients. These were not materials I use regularly for implants. So were the implants responsible? Or were my surgeries having the same outcome and consulting other surgeons? Conventional teaching from teachers, colleagues, conferences, gut feeling and anecdotal gossip that such and such implant is just rubbish, teaches us things about certain exposure risks. But when you start looking at the literature, you'll see bunches of reports of orbital implants published after each new product is marketed. There are only a handful of papers which talk about outcomes of implants, and they have short follow-ups, 1 year or so, and they combine enucleation and evisceration. When you sort out the enucleation and evisceration, you see the implant exposure is 5 to 20% post-evisceration. There are published studies on exposure risk in infected eyes, including one from our country, which puts the risk at 10 to 12%, which again comes well within that range of 5 to 20%. So we wanted to analyze the risk factors for implant exposure after evisceration, and we chose group A as the cases, 32 eyes with implant exposure, and controlled 61 eyes without implant exposure. These were operated by multiple surgeons, including resident, fellow, general ophthalmologist, and trained ophthalmic plastic surgeon. They were analyzed for the potential risk factors for exposure, and analysis was planned. In the two groups, the cases and controls, the mean follow-up in group A was 18 months. In the controls, the follow-up was 36 months. The implants used included silicone, indigenous porous polyethylene, hydroxyapatite, and aluminum oxide. The interval to implant exposure in the cases group was a median of 18 months. The follow-up of control group was a median of 37 months. So there was very little chance that we'd missed a potential exposure in the control group. More than half the patients presented with pain, discharge, or bleeding. So there was some kind of symptom. When we look at the average implant diameter, there was no difference in the two groups. When we started analyzing the other factors, including the porous implants, once again, there was no difference in the case group and the control group. There were anecdotal reports about indigenous porous polyethylene implants, and so therefore we analyzed that separately. That again was not significant. Placement of a 20 mm implant in a thiacical scleral shell, which might indicate poor surgical technique, that also was not significant. The limitation was there was no uniformity of surgeon or technique, so we were not able to analyze those two factors. We would conclude from this predominantly negative study, we get some very interesting conclusions. The average interval to exposure is 20 months. So only long-term analysis for any implant is valid, not a 1-year follow-up. More than half the patients are symptomatic. So alertness will help to pick up early detection of implant exposure. No particular implant material is responsible. So instead of being influenced by marketing, we should choose the implant that we want to use. Size is not significant, so we don't need to undersize the implants, and we aim towards adequate volume replacement. Placing an implant post-endophthalmitis is perfectly acceptable. So therefore, saving the patient a second surgery of putting a secondary implant placement. So from these negative points, when we take out everything, we have only the surgical technique left. So it's a hypothesis, but we hypothesize that meticulous surgical technique is the key to reducing implant exposure. Thank you.
This is a very good paper, and I fully agree with the conclusion that meticulous surgery should be done, because in our cases for retinoblastoma eyes where we enucleate, we find the cases done by the junior residents, they are the ones which expose more, and done at the consultant level, they don't get exposed. So maybe a study with the trainees and
trainees versus
yes, it can be done.
Faculty.
Just
that
to prove your point.
That might. Thank you.
Thank you, Dr. Roshmi.